Okay, here you can see the CT scan brain with contrast, and you can see these images. And on the right side, you can see that there is a thin rim capsule, which is hyper dense on CT scan, and then there is hypodensity within it. And you can see there are some irregularities along with the borders. So these are basically the vascular formation which occur during the formation of the capsule. And such kind of lesion, when you see on a contrast image, you can consider that this would be a CT scan brain, abscess brain, right? So these will be a ring enhancing lesion present on CT scan. It is called a donut sign as well, representing spherical wall capsule of the abscess, contrast enhancement being result of the breakdown of the blood-brain barrier and hypervascularity of granulation tissue. دا مخکې چې ما درته و دا تاسو وګورئ دا کپسول چې کله فارم شوی دی د دې سره که چیرې تاسو نږدې وګورئ واړه واړه هایپرډنسټي نور هم موجود دي دا بیسیکلی واسکولر فارمیشن دی د دې abscess سره. So the contrast enhancement being a result of the breakdown of the blood-brain barrier and hypervascularity of the granulation tissue. Non-enhancing abscess center is pus in non-viable debris. دا غمانځي که چیرې تاسو وګورئ په د سکین کې نو دا چې دی لکه contrast enhancement نه کوي. contrast enhancement په هغه ځای کې کیږي چېرته چې بلډ موجود وي چېرته چې بلډ لاسرسی نه لري هلته ویسلز نه وي په هغې ځای کې نو بیا contrast enhancement چې دی نه کیږي. نو د دې د وجې نه هر هپسس ته تاسو ګورئ د هغه یو واسکولر کپسول وي او په سراونډینګ کې او په منځ کې چې هایپونیکریټک پورشن وي هغه نان وایبل ډیبریز چې هلته اکمولیټ شوي وي. Commonly extensive edema of vesogenic type in the surrounding white matter. صحیح دی دا تاسو وګورئ په دا لیفټ سایډ ایمیج کې چې تاسو ګورئ دلته داسې فنګر لایک پروجیکشن چې تاسو وینئ دا ټول چې دی abscess دی. نو کله هم چې تاسو سټي سکین ګورئ په هغې کې که چېرې تاسو وګورئ چې په دې کې ویسوجینک ایډیما دی رنګ لایک انهانسمنټ دی پکې او بل دا دی چې د دې څلکای او ګایرایز چې دي د هغې افیسمنټ ګورئ د منځ نه تللی دی برین چې دی ډسټنډډ دی او په بل طرف ته که چېرې تاسو په کنټراسټ امیج ګورئ چې هلته یو کپسول دی چې هایپرډنس دی او منځ کې چې دی هایپوډنس دی او دا کپسول چې دی سموث دی داسې نه دی چې irregular دی irregular کپسول چې دی بله معنا ورکوي. Differentiation between pseudocapsule and true capsule may be achieved by a delayed scanning after IB contrast. ځینې وخت کې داسې چې کله early cerebritis and late cerebritis, you remember from the stages which we have seen for the abscess. In early and late cerebritis, there is no actual capsule formation, but somewhat one can claim that there would be a pseudocapsule. In order to differentiate it from the true capsule, you have to be waiting while acquiring MRI for the patient with contrast, right? Before contrast, like you cannot see the capsule at all. Like at the initial step of providing contrast to the patient. In that case, there you can see that in early and late cerebritis stages, there will be a pseudocapsule. But a true capsule can be visible with a standard midterm MRI.
Yes, sir. Clear data, sir.
Okay. In cerebritis, the center of the lesion will fill with the contrast, whereas in mature abscess, there is never enhancement of the pus-filled center. So you can say that in early and late cerebritis, as the brain within the capsule is viable, the capsule is not that much accurately formed, and there is still a blood vessel supply to the center of the abscess. In that case, you will see that there is some contrast enhancement. So this is the point where you can differentiate either the abscess is matured or not, right? Thick or markedly irregular wall suggests a tumor rather than an infective lesion. I mentioned before in the CT scan, if you look at here, this capsule is considered as a smooth wall, right? It is considered as a thin wall. Rather than in high-grade glioma, you will see that the capsule is not smooth. it is not well circumscribed. Rather than it would be regular, and some point it would be thick, and in some point it will be a thin one. So that is the point to differentiate how high-grade glioma look like, to differentiate it from capsule-formed abscess. So these are some differential diagnosis for the brain abscess. Like this is anything which is inside the brain and is capsule enhancing, they differentiated with the following categories. Like the first one is the brain abscess. We mentioned 3 specific points for it. It was a thin-walled, regular capsule, hyperdense on CT scan, with a central necrosis, which is hypodense. A primary and metastatic brain tumor, then if we go further, we can see that some lesions are solid, some are cystic, but we have to see the tendency of the metastasis. This is more for the posterior fossa rather than for the supratentorial region, right? But metastasis to supratentorial region and the vicinity of the middle cerebral artery is also a possibility. So you can see that METs generally will be located at the cerebral hemisphere near the subcortical area, whereas the abscess will be located somewhere deeper than that, right? So you can differentiate in that term as well. But in metastasis to the brain, there will be some history of the patient with the primary lesion somewhere, like in the breast, in the lung, and somewhere. You have to evaluate it. But normally, those patients who comes to neurosurgery, if we are going to evaluate them for metastatic work, we do too much work for them that it's very easy for us to differentiate either if it's a metastasis or a brain abscess. Patient with a brain abscess, they present like mostly young people, but those with metastasis present more than like 50 to 60 years of age. And there are some radiologic differentiation between them. We discussed onward, inshallah. The other differential diagnosis for a cystic, for a ring-enhancing lesion is subacute ischemic infarct, which you can differentiate on FLAIR image. And as I mentioned earlier, cystic glioma is also the differential diagnosis for a ring-enhancing lesion. But in that case, the capsule will not be smooth and there will be cystic solid component. Resolving hematoma can be differentiated on FLAIR images, and demyelinating disease will be present with somewhat patches in the white matter, maybe in the white-gray junction. So these are things you have to remember, that these are basically the ring-enhancing lesions which you have to differentiate. But always keep on the top 2 lesions, that is the brain abscess and the cystic glioma. MRI is more sensitive. As we know that for anatomy, we do CT scan, but for a smooth tissue, for soft tissues, we do MRI. MRI is more sensitive than CT scan, variable in changes with the stages of abscess, like I mentioned before. If we do MRI in the early stages, we cannot see the capsule, right? But we will see that there is some hyper intense area in the same location as we were mentioning in the CT scan. But with the passage of time, with stage 2 and stage 3 and 4, slowly, as we know that the progression of the capsule is there, we can find that there will be a specific capsule. So CT scan varies with the stages of the MRI. MRI varies with the stages of the abscess. MRI in the early cerebritis stage, T1 weighted image, poorly enhancing area within the iso-intense to mildly hypointense edematous region. And T2 weighted image, L-defined subcortical hyperintense zone can be present, but there will be no capsule. In late cerebritis, T1 weighted images, thick, somewhat irregularly migrated rim appear iso-intense to mildly hyperintense. On T2 weighted image, central necrotic area is hyperintense to brain tissue, and rim iso-intense relative to relatively hypointense. MRI in the capsule formation age, collagenous abscess capsule is visible prior to contrast. Then thin-walled iso-intense to slightly hyperintense ring that become hypointense on T2 weighted MRI. Diffusion widget and apparent diffusion coefficient images are some other entities are MRI. In pyogenic abscess, diffusion method image increase signal centric, right? C. Here you can see that in the image A, this is I think one method image where CSF is dark. You can see that there is a ring enhancing lesion which is hypointense, right? And then you have a B image, which is a contrast image. That is early contrast image. On contrast, you can see that there is hyper intense capsule with hypointense center, with peripherally vasogenic edema, which is compressing the brain on the contralateral side. And then you can see on the ADC, you can see that there is a hyperintense area, right? And the rest of the brain is hypointense. And the down, you can see that there is a hyperintense CSF, which is T2-weighted image, right? There is a hypointense capsule with central hyperintensity and peripheral vasogenic edema. And then you can see the flare images as well, that there is a edema with a hypointense capsule and then somewhat ISO2 hyperintense center. And then finally, you can see that there is restricted diffusion. And you can see there is a dark point inside. So these are different entities of the MRIs. Inshallah, in the lecture of MRI, I will explain you what is T1, T2-weighted contrast and other kind of images which MRI do produce. We will have a specific lecture on MRI, so it will get clear to you. For now, you have to know that all the sequences MRI you follow, you will see somewhat differentiation between this lesion. This is very important to understand in terms of if you differentiate this abscess from a cystic glioma or other kind of ring enhancing lesion. So you have to remember it. This is a steep learning procedure you will learn when we discuss the MRI, inshallah. One important radiological investigation you have to do for the abscess is MR spectroscopy, right? The MR spectroscopy evaluate the biochemicals which are present within the brain, and then these biochemicals are evaluated on the MRI through a certain peaks or graphs, right? So from the graph, you can understand that if the lesion which is ring enhancing in the MRI, either if it is a cystic glioma or a brain abscess, right? So MR spectroscopy produce different kind of peaks. We will also discuss, inshallah, in one lecture. Basically, this CT scan, this MRI, the MR spectroscopy, all need separate lectures. We have to explain it to you. But inshallah, within next lecture, I will combine MR spectroscopy and MRI together so you can know it better, right? So MR spectroscopy is basically the entity which differentiates brain abscess from the cystic glioma, right? And the brain abscess on MR spectroscopy, it shows lactate and succinate, these kind of peaks. Whereas the cystic glioma or high-grade glioma will show a choline peak. And then there are some other ratios which we have to compare with it, but I'm not going to go into the details. On MR spectroscopy, you have to be understanding that the lactate peak will be high. Leukocytes labeled scan increase uptake of labeled leukocytes than normal, highly sensitive 100% and specificity is 94%. However, optimal image take 24 hours. So these are things. Normally, we do not do leukocyte level scans. We only do MR spectroscopy and MRI with contrast, which can easily differentiate it for to decide if it is an abscess. In general, the principle of treatment are appropriate antibiotic with or without surgical drainage, treatment of complication, that is hydrocephalus, fits, eradication of primary source, right? We know that in some cases, majority of the cases, the primary source is in the lung or somewhere in the middle ear or somewhere in the nose, which cause infection, right? And the other thing is due to raised intracranial pressure, there can be hydrocephalus in the patient. We have to treat it. And most patients, those who have lesions in the temporal lobe, can present with fits. For them, we have to control their fits as well. So this is basically general management. Treatment option, the choice between conservative versus operative treatment is influenced by age, right? And neurological status, location, number, size, and stages of the abscess formation. This is a neurosurgeon have to understand it. The medical management, antibiotic therapy during early stage prevents progress from cerebritis to abscess. Right? So if the patient present in stage 1 or 2, early or late cerebritis, it can be controlled with the antibiotics. For example, if we do CT scan for the patient, if we think that there is some lesion in some area, and then we do MRI for the patient, we do not see any apparent ring enhancing lesion. In that case, we can give patients with antibiotic, right? Patient who have symptoms for less than 1 week have a more favorable response to medical treatment. Less than 1 week means the early stage of the severities, right? Patient demonstrate clinical improvement before significant changes in CT scan. Improvement on CT generally observed within 1 to 4 weeks, average 2.5 weeks, and complete resolution is 1 to 11 consecutive. मतलब अगर शुमा बरी मरीजा antibiotic बतें the early stage, شما اگر سیتی سکن برشان کنین میتونه که یک مریض تا 11 ماه در سیتی سکن تغییرات دیده شود. اینمی جای است که شما بفهمین که you have to stop doing CT scan for the patient if the patient's symptoms are relieved and if you think you are doing well, then you are not supposed to follow the patient on regular every month like CT scan, which is hazardous for your patient. Antimicrobial treatment generally should be long, IV 6 to 8 weeks, followed by oral 4 to 8 weeks. Depend by میکنه که شما صرف aspiration کردن یا capsulectomy کردن, right? Generally, ما که اینجا مریضا را treat میکنیم. Majority of the patient we do aspiration for them. We give them IV antibiotic for 6 to 8 weeks, followed by oral 4 to 8 because of the prolonged time needed for brain to repair and close abscess space. If medical treatment is chosen, CT scan can be done weekly during treatment and monthly after discontinuing treatment and enhancement disappears, right? اونجا گفته برای شما که تا 11 ماه enhancement disappear نمیشه. به او خاطر اینجا کنتروورسی بین مختلف کتاب‌های نیوروسرجری موجود است. خب باز ما به اینمی پلان را پیش میبریم. Median diameter of the abscess that resolve with is 1.5 centimeter, 1.7 centimeter. No abscess for more than 2.5 centimeter resolved with antibiotic alone. یعنی اگر یگان ابسیس است که اگر سایز از او 2.5 سانتیمتر زیاد باشه توسط صرف antibiotic باید resolve نکنیم. It depends on the size of the abscess as well. So more than 3 centimeter abscess normally we do aspiration for them. But abscess smaller than that and with non-equivalent areas, not well capsule enhancement and central necrosis, if it's not present, we consider this early 3 stages, and that cases we provide antibiotic to the patient. These are some the predisposing factors and antimicrobial regime for them, right? What we give is we give extended spectrum antibiotic to the patient because brain abscess is a neurosurgical emergency, and we cannot compromise the life of the patient by providing them somewhat like low spectrum antibiotic. We have to be going with extended spectrum. So from the very start, we give them 3rd generation cephalosporin and metronidazole, right? Majority of this patient. But we have to look for the predisposing factors. If the patient is with otitis media, this is one regime, and then there's sinusitis, other dental abscess, other regime. A penetrating trauma or post-neurosurgical, we have to go for vancomycin, that is very extended spectrum. But majority of the neurosurgeons, I have seen practice here in Pakistan and different places, they go with vancomycin from the very start because we don't know the nature of the microbes. Indication for surgical drainages, no clinical improvement within a week. اگر شما برای کس antibiotic میتین و کدام تغییری در حالتش دیده نشود, you have to be going for surgical drainage. Depressed sensorium, increase in intracranial pressure, progressive increase in the ring diameter. اینمی 5-6 چیز است که شما ایرا دیده و surgical drainage رفته میتن. Aspiration yak approaches, endoscopic stereotactic evacuation diga approaches. Aspiration agar shuma bibinen ke abscess gas sathi است subcortical است شما برشا كذا ميتا صحيح بخاطر كي less neurosurgical neurological deficit بيكون واسبيريشن در تمام ستيج ها شده ميتا but in early cerebritis late cerebritis avoid aspiration, please go with antibiotics. यागान वक्त अगर शुमा BCR expert هستین شما neurolocalization خوب است شما میتونن که بدون ultrasound و CT scan guided کنید. خب این practice که است که ultrasound guided و CT scan guided it is not that much common in different neurosurgical departments. Majority of we do as straightforward aspiration through localization of the lesion. Endoscopic stereotactic evacuation ای هم که اسیرا مردم زیاد تشویق میکنه خو ای بخاطر میکنه که اگر ابسس در eloquent area باشه و شما میتونین که توسط نیورونیویگیشن او را لوکالایز کنین باز امرایشان فریم بسته کنین باز امرای فریم stereotaxy کنین و under MRI guidance که شما او را drain کرده میتونین. Excision of the removal of the capsule. In late capsule stage, one of the option is excision. If you do excision of the capsule, it shortens the duration of antibiotic to 4 weeks. Like before, I mentioned that we give IV antibiotics from 6 to 8 weeks, and then we oral from 4 to 6 weeks. Here, this is up to 3 days in some cases, but this is not reliable. You cannot compromise on providing antibiotic to the patient with a brain abscess. Excision can be an indication for excision or multinucleated abscess, abscess caused by more resistant pathogen, abscess containing gas, post-traumatic abscess containing foreign bodies or contaminated bone fragments. Abscess is relevant for fistulous communications. All right. Okay. So these are the excision indication for the abscess. The contraindication of the excisional abscess in the cerebritis stage, like I said, that you have to provide antibiotic to such patient. Deep-seated abscess in eloquent areas, right? You have to do either stereotactic aspiration or either you have to be antibiotic, but stereotactic aspiration is far more better than these things. In multiple abscess, for example, if there are multiple abscesses in the brain, which of the abscess can you remove? So for that purpose, that is not indicated. What you have to do is you have to take the pus from the patient for culture sensitivity. You send it to the culture sensitivity. You find out the organism, and then you provide medicine as per culture sensitivity, right? So these are some contraindications. Steroid use, we know that vesicogenic edema can be reduced by steroid use through a mechanism which I mentioned in the lecture of the head trauma. It reduces the mass effect of the patient. But disadvantage of the steroid use is reduced contrast in the CT scan, right? So if you give like glucocorticoid to such patient, it reduces the contrast enhancement, right? It changes the vascular wall of the capsule to a fibrotic one. That's why the enhancement is decreased. It slows the capsule formation, increase risk of the rupture, right? We know that the capsule is thick towards the hemispheric side, towards the brain side, but it is very thin towards the ventricular side, and there is less vascularity, so there are greater chances that abscess can rupture into the ventricles and decrease penetration of antibiotics. So generally, you have to avoid, if you see that the abscess, the edema is less in the surrounding, in that case, you have to avoid providing steroid to the patient, and also you have to avoid in the early cerebritis stages as well. Complication of the neurologic deficit, commonly seizures with frontal lesions, poor prognosis, mortality rates up to 30%. That's why it is considered neurological emergency. Rapid progression of the infection, if ruptures, severe mental changes, right? Patient present with deteriorated level of consciousness and rupture into the ventricle. And like I mentioned, that towards the ventricle, the capsule is thin as compared to the other side towards the brain. The outcome is the mortality and cerebral abscess is from 0 to 10%. Neurologic disability is 45%. Dead focal or generalized seizure 27%. This is very important to remember. For example, if you remove the abscess of the patient through excision or aspiration, and then somebody asked that my kid was having seizures before this surgery, what is the outcome? You have to explain that in 25% of cases, patient will be having seizures. They have to know it. And hemiparesis in cases if the abscess is more than 3 centimeters large, and it caused midline shift to the patient, and patient presented with decreased conscious of level, and then you have treated the patient late, and that case patient present with hemiparesis. So hemiparesis is more common than seizures. And overall neurologic disability in the patient is 45%, and mortality in cases of brain abscess is 10%. Thank you very much for listening.